Okay, what are we starting with here?
Our introductions, I'm gonna specifically say that we chose to introduce ourselves because this is about voice and choice, and we want to show how we have to develop our own voice.
Oh, you got it. Let's get right up there.
Yeah.
Do you need anything? Water?
Yeah,
Coffee?
no water. There's so much, my head is so full of stuff. No, just so full of stuff.
From today, just a lot of. I'm all set, thanks, David.
Sure.
Yeah, I am, thank you. Actually, I probably should have a water up or just. I got it.
Right now. Remember, is that still here?
Yeah, she's still here. She's
She's supposed to be proctoring your section. Remember, you can, you guys introduce yourself.
And there's a lot going on, isn't there?
You know, it's brought back so many memories. I remember being in 13 and in jail. Turn around and smile.
I'm gonna get the screen in here too. Oh, that's.
What a pain in the butt. But I was remembering, you know.
So I got you with the screen in the back.
So good.
Good.
Okay, we're covered, I know. Incorrigible, right?
It's going on TikTok.
Yeah, what's going on?
It's going on a dartboard.
Okay,
Break the leg.
Thanks, Steve.
but I remember that there was these guys pat me down, the police officers, and there was no females there, it was just males.
You're how old? 12 or 13?
I was just starting to develop. And they were sitting there making fun of, you know,
Yeah, your lack of development or
just,
puberty. Yeah,
so when she was talking about that, I was. It's a different kind of humiliation, you know? But anyways. I would also like to end on a good note here. Where we're positive. You know, it's like that woman when she was talking, I wanted to say, you know, do you remember when I talked to you about getting a lobotomy? Okay.
Yeah.
I mean, I was so distressed
yeah,
that I actually talked to you about it. I'm glad now that I didn't,
yeah.
but I actually asked you
Gave
about it.
consideration to it, yeah.
Yeah. So I really get where she's coming from. But I wanted to say, you know, there was a time I thought about a lobotomy.
I mean, see, I think the reason why this is a good finish is that a lot of what we want to convey is that with a lot of work between two individuals who come from completely different perspectives,
Yeah,
you and I developed a very interesting relationship with advocacy.
right.
So you taught me what advocacy was about, and I helped you gain some self-advocacy,
Yes.
right? You found your voice through a lot of our
Yeah.
text messages and, sharing.
Yeah, some of that was pretty direct.
Well, I mean, but it's because you guys taught me how to be loving and direct. And then even like the poetry where we were changing stanzas and trying to look at life differently and all these things, right? That's
Yeah.
fun about
It was another connection.
Yes, yes.
There's so many different ways of connecting.
Yes, and that's what you teach in Pathways.
Yeah.
It's
All right, folks, we're gonna go ahead and get started again on our next hour.
My God, she's on.
Thank you all for coming today. We're grateful, so glad to have such a good turnout.
David.
I'm Deb Brookshire. I work at Catholic Charities, but I'm also the program administrator for Catholic Care Support, which you heard about at lunchtime.
We'll see.
Our next and last session of the day is patient voice and choice. self-advocacy and the difference between collaborative and coercive care. Our presenters are Trish Risser and Dr. James Mooney. Now, Trish has been involved in peer support for over 20 years. She's an active participant at Pathways and is a certified peer support person. And she helps take some of our group, and she just does it at will in the community with anybody who calls her for help. And Dr. Mooney is a trauma-informed medical provider of internal medicine who has a particular interest in the impact of emotional health on chronic medical conditions. His 30 years of practice in hospitals, outpatient clinics, nursing homes, hospice administration, and community outreach has developed his perspective on care. He believes that the adverse childhood experiences study could serve as the foundation of understanding chronic disease. Now they asked me if they can introduce each other and tell you a little bit about how they came to know each other and work as a team, and how it has helped them both grow in their experience. So thank you. I'd like just to welcome these guys. Thanks.
So thanks for having us. I hope we can bring this to a exciting and positive close. There's been a lot of great information today. I appreciate the fact that Dave and his team even considered me, but I think what's nice is that what Trish and I have developed over the past 8 or 9 years is really the culmination of what I've learned from the Mental Health Recovery Board, how I've practically applied it to my work in hospitals, and then what Trish has taught me over and over and over again about advocacy. So we look at the title as helping others help themselves. And we want to look more at the collaborative idea rather than the coercive idea. We want to move away from coercion to collaboration. Okay. So I do want Trish to talk a little bit about her work at Pathways. The other thing we want to do is we want to introduce part of ourselves, because that's part of finding your own voice. We have to feel comfortable telling who we are, why we're here, what we do.
Really? I'm okay, you start.
Okay, I'll start. So the most important, there were 2 things in the introduction that they talked about, that Deb talked about. One was about the trauma-informed. I consider myself a trauma-informed physician. And secondly, was about the adverse child experiences study. So that is the underlying theme for me, because I work in the medical arena, not the emotional health or mental health arena, which is kind of ridiculous because they overlap, completely. But there are silos, unfortunately, in our healthcare delivery system. But because of my relationship with Steve Stone, Pat Risser, David Ross, Todd Yorty, who does counseling in the community, Jerry Strasbaugh, I could name almost everybody in this room, certainly Dennis at Akeda. So these were people that introduced me to it over time. And then when I learned that there was a common language in the adverse child experiences study that I could take from the emotional and mental health realm and bring it to the medical realm, I finally had something that I could actually speak to that really spoke to me, that I could actually speak on behalf of others.
I'm ready.
Yay.
I was thinking when me and Pat first got involved in mental health, one of the things that we had talked about with a bunch of people who unfortunately aren't here any longer was what that would look like. And what we came up with was a version of like AA, whereas peers would help peers, because we felt that we weren't really being heard by the medical model. People couldn't really understand where we were coming from. And if there was an emergency and you call up, there was a 2-week waiting list before we could see somebody who might be able to help us. Maybe. Okay. And we had to see who they wanted us to see. We couldn't pick our own therapist. You went to community mental health and you saw whoever they had, whether that person suited you or not. And so the talk was a lot about, let's do this as peers. And the idea was, as peers, we would be able to talk to each other in a way that nobody else could really understand. And to this day, I believe that. I believe that a peer can, because let's face it, you know, who has lived on the streets? Which one of you has lived on the streets? How can you understand what that might be like? I mean, you could get an idea, but who would really know what that's like here? And so we could show a little more patience with that kind of, I don't want to say brokenness, but that kind of damage. We could show a little bit more compassion. We can understand why that person maybe stole from the grocery store, you know, to eat. We could get that. We could understand the hopelessness of trying to live that kind of existence. And so that's what the goal was. Then come to my surprise, we're kind of not like that. I mean, Pathways is like that, but we've kind of turned into a little bit like mini social workers. You know, that's not what we wanted. We wanted to be able to go out to coffee with somebody at 3 o'clock in the morning. We wanted to be able to, you know, let somebody sit there all day long if they needed to, you know, among a group of people that understood. If they needed to go to the quiet room, it was okay. We wanted to be able to meet people where they were at, not where we thought they should be. You know, because when we meet people where they're at, they've got to buy in. And when they've got to buy in, they start moving towards that buy-in because there's an investment. Now, if you start telling people what to do, there's no investment. They're going to stick up their backs and fight you every inch of the way. And yes, you'll probably have to have somebody go over there and give them meds because they're not going to take them willingly. But if there's a buy-in, that's a whole different thing. I'll buy a buy-in. That's how I got caught. That's how I got caught up volunteering at Pathways. I bought in. And I still buy it because I've seen it over and over and over again. Like David said, we don't catch and keep. We catch and release. We find out what people want. We find out their buy-in. And we take that buy-in and we help them meet that buy-in so that they can go to work if they want to. And if they need supports after that, they've got those supports. If they need to talk to somebody, need to meet for coffee. You know, I'm probably not supposed to do that, but I do that. You know, I will meet people for coffee and let them talk if they need to, because that was my idea of what a peer was. Now, I won't tell you what the guy who ran ethics told me. You know, you can kind of guess, I'm sure. But the thing is, that was the right thing to do. And that's what I believed in doing. That's what Pat believed in doing. I think even Steve will agree with that. And, you know, one of my bosses here, she just pretends she doesn't see it, right? I'm talking about going out for coffee. You said, I know you do that. Yeah, thank you for that, by the way. Thank you for never nailing me on that. I appreciate you. And I appreciate Deb because she understands where I'm coming from and she doesn't try to put all these limits on me that guess what? You know, they render me ineffective. And I'm effective because I do go to where a person's at. Now, have I talked long enough?
No, that was beautiful because here's the point, right? So over the course of these next 30 to 40 minutes, we're going to talk about how Trish found her voice, because Steve and I could go back 9-10 years and she's going to share a part of her story on the physical realm.
It's their fault.
Where I'm not taking responsibility for that one. So that's nice. So you can hear it. She has passion and the passion exudes from her. And that's really what we're trying to do. That's the best example of self-advocacy. A person who understands it, who found her voice and did it admittedly over many years, and it wasn't easy,
Yes,
right?
no.
And so I showed a picture here of Pat. Actually, Trish took this picture. I asked her if she would mind me using it, and she said she remembered using, actually taking that picture. But the reason why
Isn't
we're
he
here,
cute?
the smile's quite engaging. The reason why we're here is that Steve invited me down to a conference in Columbus, and I had given a talk about the connection between emotional and physical health. And Pat was not one to sit quietly. So after the talk, I see this guy charging at me. I'd never met him before, and he's like kind of like almost pounding the table. And he said, you have to, I have to meet you specifically. I have to meet you. And I said, okay. So I didn't really have any choice. I was like, okay, that'd be great. So he brought me to the Mental Health Recovery Board when we were over on 1095 right there. And that was the first day I met Trish, and Trish sat there very studiously with a pen and paper and showed some incredible insight about topics that I just didn't anticipate she would have so much insight on. And she was really doing it for Pat. And I thought, well, this is interesting, because Pat called me in and Trish was, incredibly insightful, taking notes, showing love and concern for somebody who she obviously loved. And so I thought, okay, this is what it means to be an advocate. And so then you were doing this quietly in the background, and then that's kind of how Trish and I met. And then we'll tell you a little bit about our story as we go forward. So that's basically what I was just saying. But my point in this is there were two things in this situation that are important to note. One was, at the same time, I was introduced to the Adverse Childhood Experiences Study. And again, I'm sure everybody in this room has heard of it. And if you haven't, obviously it's a must read. But the reason why it's so important is because that is fundamentally the way that the emotional health realm is going to connect with the medical society. I'm 100% sure of that. It's a common language. It creates virtually every chronic medical illness that I deal with on a daily basis. And it costs the system enormous amounts of money. And so it sounds incredibly mercenary, but the fastest way to get people to listen to you at any level, at any board, in any hospital, is to talk about money. And so that's all I do. So every time I go, and I think Rob's point this morning or throughout the course of the day was about statistics. If you don't bring something that somebody can sink their teeth into, it becomes anecdotal and they just kind of try to dismiss you. But when you bring money into it, everybody hears. And there's chronic illness costs our system money. And that's where the Adverse Childhood Experience Study could teach them a lot. And the second thing is that Pat invited me in. And so while I knew everybody on the periphery, Pat demanded that I meet him at the Mental Health and Recovery Board. Demanded in a love way. He was just an engaging guy. But so I encourage everybody in this room who probably doesn't spend a lot of time on the medical realm in your interactions, maybe with some frustration, but you do it oftentimes in the emotional and mental health realm. We have to figure out how to intersect those. So invite people in. Tell the quick story about your physician assistant, because I think it's applicable.
Okay. Well, after Pat died, I found out I had a dying liver, and I would need a liver transplant. So Pat just dies, and I find this out. And so I'm going through all those motions, and so Jim's aware of this, and he's helping me with all of this stuff, and Steve's helping me with doctor's appointments, and we're getting this taken care of. And right after my surgery, I had this physician's assistant call me up, and I didn't make an appointment because my car broke down. And so he was really, really rough. I mean, he said I was acting like a baby. I wasn't getting to my appointments. And the kicker was, he said, the team regrets ever giving you a liver and kidney. Now, I had a really hard time taking this liver and kidney to begin with, because I thought somebody younger deserves it. Somebody younger should have it. Somebody, that has more of a future than I do, should get it. Wouldn't you kind of think that? Here I was almost, well, okay. No, maybe not. Okay, well, that's what I thought. So I had a hard enough time, accepting this. And I actually talked to Jim about it. Said, don't you think that I should give this to somebody? And he said, no. So I was really vulnerable. Anyway, so this is about 2 weeks after my surgery. And I just fell apart. And I wrote Jim. I mean, I was crushed. And I wrote Jim and I said, Jim, can you advocate for me? I don't ever want this guy to call me again. Or I don't ever want to see him, in my doctor's office. I don't want to have anything to do with him. And so Jim's listening, and he's very patient. And then he says, well, aren't you a peer supporter? And I said, well, yeah. Yeah. And he said, well, what are you going to tell people about advocating for themselves if you can't advocate for yourself? And it was like, are you freaking kidding me? You know? And I just like, my mouth dropped open, and I'm sitting on that chair and I said, all right, this is how much I love this program and how much I want to, help. I said, all right. So I stayed up all night long worried about it, right? And the next morning I called the transplant team and I said, I don't want this guy to call me. He was very abusive, and I didn't tell them about, the regret. I couldn't face that myself. So I never mentioned that part. But so the next time I went to the doctors, the surgeon said to me, we got your message, and so admitted he was abusive. And I was so grateful he didn't gaslight me. And he says, but the guy was busy, he was stressing and blah, blah. And I thought, man, I had surgery 2 weeks ago and he's stressing. Yeah, I don't think that was very professional, right? So, but I was so grateful that he owned it. I was so grateful. So I called Jim and it's like, yay, and I felt so vindicated and so powerful. And I will never give up my voice again. And from that, I have learned to stand up. And I hope because of that, I'm learning to teach other people to stand up, because that's important. And so, Jim has really worked with me on some of that stuff. And it's been incredible. Yeah, now he tells me, shut up.
And the beauty of it is we'll talk a little bit more about that a little bit later in the talk, but it's also because Trish was working with me. So she was teaching me things about the emotional health realm and what advocacy meant. And then I was able to share back with her about how she could speak up for herself in the medical health realm. So it was really a perfect collaboration.
Yeah.
But so here's what one of the things I wanted to tell that story now, because that's really about trauma-informed care. Clearly that provider was not trauma-informed. You're talking to somebody who just went through a transplant, two organ transplant 2 weeks ago.
Yeah, 2 organ transplants.
And you're telling that person that they're acting childish, or that it doesn't matter. You cannot even imagine what kind of shock that should provide a system. And yet people just shrug their shoulders and think well, she's behaving that way. Well, of course, ask why, what happened, right? So we want to talk a bit about trauma-informed care. We want to talk about some practical ways to help people find their voice. And then, give some real practical things about the tools of how to do that. And then lastly, how that once you find your voice, really what that does, right, is it opens up all sorts of things. It opens up choices, but your choices, not somebody else's.
Yes. And this way you have a say in your choices. So you often go to the doctors and you think, well, I just have to do what they tell me to. I have a lady that I was helping that is a professional, and even she was afraid to go to her doctors and confront him on some stuff. I went with her, we role played, and she ended up not needing me. But the thing is she went there and she was brave enough to confront the doctor, and they started building a relationship. And isn't that what it's all about, is building that relationship so that you can work together for a buy-in for both of you. And doctors become doctors because they want to help. So you're giving them an opportunity to help you do what you want to do with your life. And that's such a gift. And not only that, it is pretty powerful. I feel, I'm ready to take on the world some days.
I put this quote in again because I always want to be mindful of Pat Risser, because he was so influential in this topic. And I also want, people to see that in the medical health realm, we have to remember this, right? I don't believe in mental illness, Pat said. My thoughts, moods, feelings, and emotions are not a disease, a disorder, or an illness. They're me. They're the very essence of my being and what makes me a unique human being. In that disease model, who we are as unique human beings becomes a disease? That doesn't make sense, does it? I mean, it's fortunately why we are different. It makes us unique. So, but
there are some things that don't work. Let's face it, we all do some things that don't work, except David here, And those things, sometimes they need adjustment. They need work done. They need help. Yeah. And, if I might say is, medication does help for some people.
Perfect timing, because I took this piece from the Mental Health and Recovery Board's three legs of the stool, right? So there's three parts of that. There's the trauma-informed care, there's the recovery, and medication optimization. And so the comment that Trish makes about medication optimization is that, yeah, there are times and places for those medications in the right context, in short order if necessary, all those kinds of things, but not to the point that Rob Whitepun was talking about where it's coercive and everything. In the trauma-informed care realm, this is very important in terms of the discussion for this connection between the emotional and medical health realm, because how often do we emphasize safety in a hospital? How often do you see empathy? Trisha's story will tell you that's sadly not uncommon. Are we giving people personal choice? Are we aware of the fact that that person doesn't probably understand what we're talking about? Time is pressed, right? So are we giving them that opportunity? Are we using language carefully? I mean, for heaven's sakes, I think we create some of these words just to keep people on the outside. It's almost like it gives us power, right? And I think the last one is the always ask kind questions. My favorite, this is without a doubt my favorite one. And this was another thing I learned from the gang at the Mental Health Recovery Board. If you ask somebody what's wrong with you, then you're implying that they're broken, they need your help, there's something inherently wrong with them, as opposed to saying what happened. So why are you here? What happened? And that's just it's an absolute must. We should never, ever, ever, ever again say what's wrong with you. And we do it all the time in the healthcare realm. And so I walk around shouting it from the treetops because of my colleagues. So I appreciate that. But that's the thing I put on the right side. It takes time. And unfortunately, what we do is we keep saying, I don't have the time, I don't have the time. Well, we create so much downstream work and so much pain and so much difficulty because we don't take the time that we have to.
Yes, exactly. And can I mention the magic pause?
Sure.
Okay. I tend to jump in. I get triggered. Man, I'm right there, right? So Steve and this guy here, they taught me about the magic pause. And that's to pause for a minute before I say anything and ask myself, are you going to be kind? Or are you going to tear their head off? If I'm going to be kind, then I can speak. If I don't, I need to go back and think about that. Because we never succeed anywhere without kindness. If we are not kind, if we are mean, if we are aggressive, if we are attacking, we lost that person before we even have them. Don't you agree? So everybody say yes. Yeah, there you go. Okay.
That's true. I show this picture because when you talk about trauma-informed care and safety and empathy and listening, I mean, this is really like the perfect scenario, right? The woman's taking notes, making eye contact. It's a comfortable surrounding. It's intimate. I mean, it's all those right circumstances. And so I could show you a picture of an outpatient clinic, but it wouldn't be comfortable. I could show you a hospital. It wouldn't be comfortable. And unfortunately, this is also what a lot of people have to deal with. The gentleman on the right side is in an alley. He's homeless. He might have, had bowel or bladder incontinence, and he's the person that we're trying to serve. The people on the right, these young children, are very likely in a refugee camp. And you can see from the different faces, the different trauma they're experiencing. So the difference between this social interaction and these social interactions are quite dramatic, but the tools that we have to bring are the same. And that's where the common language becomes helpful. Because when I'm in the hospital in a code situation and somebody's dying, that's not this situation, I can assure you, because emotions are high, people are frustrated. There's anger, right? Because if something didn't go the way I expect. So we have to be aware. Trauma-informed care is a must for this message. I want to go back to Trisha's story about the transplantation, because this is, let's talk a little bit about the progression of the first time that you heard you needed a transplant and some of our early conversations, and how the doubts and the fears and everything came in even before the transplantation.
Oh, yeah. But you're going to have to tell some of that.
I'd be happy to.
Unfortunately, when my liver went bad, I had a lot of toxins in my brain. And so because of that, I have missed a few things, and some of those things I probably will never get back, but that's a conversation I don't remember.
So one of the biggest things, Trish remembers a lot of the details after the fact, but
Yes,
this was not too long after Pat had died when when the issue became more problematic. So we were separating a physical illness from an emotional illness. And interestingly, from the ACEs study, Trisha's liver disease could very likely be related to her childhood trauma. So it was a very strong correlation for something that was suddenly becoming very real to me. And now I had this, trusted friend and colleague who was mourning the death of a really impactful human being who not only changed all of our lives, but very intimately changed her life. And then she has to face this mortality of this decision of a transplant. We're not talking about maybe even just a heart bypass or a stent. I mean, this is literally taking an organ from one person to another. You can't think of anything more dramatic in healthcare than a transplant. And so we had months and months and months of conversation. Steve and Trish and I got together on many occasions talking about, am I worthy for this? Is this a valuable experience? I don't deserve this. I mean, you even, you went so far as to thinking about the person who was giving it to her when that time came. What's that going to look like? So what was so powerful about that is that at the time that she was most vulnerable, at the time when she was probably the most doubtful about your own value, that's when advocacy had to come from somebody else, not from herself. She didn't have the emotional strength at that time. So after the fact, when she had the transplant, because we had all that previous conversation, I could challenge her a little bit. Speak up, Trish. Tell them. And she did it I wouldn't have sent her out to that first experience without all of that background. But when you went through the transplant, then you did find a different perspective.
Yes.
Very strongly.
well, and the idea that, he challenged me and said, well, gee, you're a peer supporter. How are you going to show other people how to do it if you can't? And it was like, and I want to show you all how to do it. Because guess what? It's your voice that's going to make a difference in your life. And in order for you to make a difference in your life, you're going to have to speak up. All of us have to speak up. And it's tough. It's tough I'm intimidated by doctors, not you. But
I guess I lost my touch.
But I'm intimidated by doctors. You have to admit, a lot of doctors are very, police, emergency room people. All those people are very intimidating. But if you say it right, if you take that pause, if you build a relationship with your doctors, then you really have somebody good on your side.
And that's probably, so if you knew Dr. Tony Post, who ended up being, Trish's transplant provider, it was somebody that I knew would be incredibly sensitive and genuine. And wouldn't you say he turned out to be?
He was wonderful. He's retiring this year and I just hate it. I don't think he should. I think he should be there for me, right?
So the beauty of it is that I knew going in that I had to connect her with somebody who would think that same way. And so I had the opportunity, because again, of what the gang had taught me over the years, to find somebody to make sure that this person who was incredibly emotionally sensitive about the transplant, incredibly emotionally sensitive about the loss of her husband, who was going into a long chronic illness, to have somebody who understood that. And so that worked out well. But it brings me to the point about the providers too. I would ask you guys to do me a favor and think about the providers that you're most frustrated and bothered by as a 5-year-old child, because their behavior is directly commensurate with what happened to them as well. And so when I was hearing the story this morning about, when you talk about drug companies, you talk about providers who are quote unquote making money off the backs of others. What's really unfortunate about those circumstances is those individuals are putting money in front of a relationship. That's not something you're born with. You learn that. That's a learned behavior. So a lot of those individuals are incredibly emotionally unhealthy. They feel insignificant. They've been told they're not valuable and not worthy. And so they are going to measure themselves by their margins. They're going to make more money and prove everybody wrong. And so that's what happens. And so we think about our own advocacy. We think about how we're being treated. But I've experienced vicarious trauma when somebody comes in and starts yelling and screaming at me because it reminds me of certain circumstances that I had when I was a child. And my first response is to get up and get ready to go. And so my actions oftentimes are reflective of the relationship that I'm in. So let's at least think about it for just a second. Imagine the person who's misbehaving. And even that story of the PA, unconscionable to say that, but the person obviously had enough trauma in their lives to disregard a human being who was in Trish's circumstances.
But keep in mind too, I protected myself. You know, that guy was never allowed to call me again, or, you know, so I gave him some slack. Absolutely. And part of that was because he admitted, you know, that he had done that. But I also protected myself from further abuse. And sometimes you gotta walk away from.
Perfect example.
Yeah.
Yeah. And you also, what's important is he didn't apologize to Trish.
No.
He apologized to a person to tell Trish. So now that wasn't exactly insightful and engaging and, you know, reflective, but maybe that's just the first step. And the fact that Trish was patient enough, and Trish told me, I forgive him. That's a really beautiful thing to do, but she had to protect herself. And so you have to separate yourself from that. But the forgiveness was there. And so that person has an opportunity to grow.
But maybe from me calling him out on that, the next person, he'll think twice about it.
Exactly,
You know,
right.
it's my hope.
That's right.
Yeah.
I put this on here because in trying to find one's voice, I like this phrase. David mentioned it this morning. You know, this is one of the statements on the Mental Health and Recovery Board. And what I want to contrast it with is, you know, is this statement true for hospital systems, and what is the difference? And I think it's kind of funny. It's one word as far as I'm concerned. In the Mental Health and Recovery Board, it says volunteers. A person who's volunteering is giving of themselves with no expectation in return. As soon as you pay me, there's an expectation. And so if I work in a hospital system and I'm being paid for my services, you're allowed to expect something of me. And so I think that's unfortunate. Money gets in the way of a lot of things. But at the premise, I mean, Trish even said it, that we have to start with the premise that people caring for you care about you. Physicians, nurses, physical therapists, occupational therapists, respiratory therapists, they go to work with the intent of trying to help. But unfortunately, they're in very stressful situations. It doesn't condone the behavior. It just explains a part of it. And so as long as we're constantly aware of that, and we teach them that this behavior is not appropriate, this is how I would expect you to treat me, and here's something that you can learn about it, then they might come along and join us.
Well, believe it or not, Jim can look very intimidating. When I first met him, I thought white shirt, white coat, pristine, you know.
I ironed it myself too, by the way.
Huh?
I ironed the shirt myself.
Yeah, I bet you
Pristine.
did. So, but he, you know, so I was intimidated, and Jim taught me that there's a human being behind that white shirt. That if you take a little bit of time, you might melt that icing off of there a little bit. And if you can't, walk away and find somebody you can work and build a relationship with.
Yeah, we always know, right? You could either change the situation or change your geography. Those are really the
Yeah.
two most basic things to do. And if the situation is completely out of your control and you can't change it, or you don't feel like you have the emotional strength to do that at that moment, changing your geography is always a good idea. And that was Trisha's point. She just needed to separate herself from that. So that's very important to think about. If you're by yourself and you don't have the emotional strength, we just have to keep ourselves safe.
And that built some self-respect for me too, because I stood up for myself, you know, and I showed myself a little self-respect. That's hard for some people to do for some reason.
And that didn't happen overnight, right? I mean, this conversation we had months and months and months of, but it was so engaging. It was teaching.
I'm a slow learner.
No, she has more depth than she's giving you right now. I can tell you that. All right. So one of the things that I wanted to put some just real practical things, the tools and resources. The Mental Health and Recovery Board website is absolutely chock full with unbelievable resources. And I suspect a lot of you know that, but we know it sometimes. And because of that, we overlook it. We have to go back to it constantly. It's refreshed. There's podcasts on there. There's links to other places. It talks about what trauma-informed care means. And when you're educating people in the community, and that's, I think, a biggest part of our obligation, is we have to teach our clients, patients, friends, families how to find their voice, but we also have to teach caregivers who are completely unaware of this, what this means. And so we have to be educators. So please go to the website. The Adverse Child Experiences Study, I'll go on and on and on. That could be a session on it by itself, you could do a 2-week-long session on that, how impactful it is for the medical health realm. But that website ACE is too high. Everybody's got a cell phone now. So maybe make a little card if you interact. And by the way, most everybody in this room at some point is going to interact with the healthcare delivery system on the physical health realm, either a wellness checkup or a follow-up appointment. Do we have little calling cards that has, a couple pieces of information on it that we could hand it to somebody and say, are you familiar with this? Have you ever heard of the ACE study? Have you ever heard of trauma-informed care? Because you could say, I noticed that you behaved in such a fashion, and I suspect you're not aware of trauma-informed care. It would help me next time coming in if you would do that. I work with Connie, or we worked together quite a bit at the hospital. How much stuff do we give to people at discharge? Piles and piles of paper that we unfortunately, do we have anything that's really pertinent that we can discuss with this, right? We don't, but that should be part of our discharge planning, right?
He's gonna put you to work. I can tell.
The Healthy Ashland app, I hope everybody has downloaded that. It's just, again, it's a nice quick connection, and it's on your phone. You're readily accessible. It's got, quick resources for you. And it also, the more we use it, the more robust it becomes. We all know that. So let's all download that today if we have our smartphones, and make sure we have that on our phone. Now, I'm actually, do you mind if I keep going? I'm kind of on a roll.
Go.
The last thing I wanted to tell you guys about, so I always think about, we have to get our message out both locally and nationally, right? So our voices, because we're all sitting in this room and we believe in the topics that we believe in, can find our national voice. And this idea of person-centered planning, I understand that Sean Terrell is a friend of our community, so that comes in handy. He does some great work on the national level. And I want to point to one thing in particular. It comes from the Administration for Community Living, but this is a Medicare-based initiative. And the reason why this is important is because if you look at that last part where it says value-based purchasing, this is where, for me, this is what speaks to me, because this is about money. When CMS gets involved in something, and they have that much coverage, and they know how much this costs, this is not going away. And so when you talk about person-centered care, that is exactly what we're talking about. We're trying to give people a voice. We want them to do those three things: choose, direct, and control their own care.
Sean Terrell is one of our online attendees, just so you know.
Okay, even better. Even better. So obviously he could talk about this, at length. But my point though is that when we take our local initiatives and we grow them in strength, and then we have an awareness of what's going on in the national realm and what Medicare is going to do to this, value-based purchasing is everything that I do all day. So the old model, everybody's probably heard of a fee-for-service model, which just means the more you come in, the more I bill. Well, that was great, right? If you want to just keep clickety, come back in a month, and you just, this is easy. But then finally somebody woke up and said, well, that's not very logical, because we're not really doing anything of any value. And so at this point now they're linking, is there value in what you're doing as opposed to the volume of what you're doing? And once you start giving advocacy and having people be responsible for their care, that actually makes my job even easier, because now I get to hold everybody accountable as well. As long as I'm aware, sensitive, kind, thoughtful, trauma informed, then we can actually make better decisions together. So let's think about both our local resources, Mental Health Recovery Board, and our national resources. And fortunately, because of the relationships Ashland County has, in a large part because of Pat Risser, we have a national voice. As a matter of fact, I can tell you, the first time I ever saw Pat at a national conference, I think we were in DC, and I was sitting at the table with him, and we walk in the room, and like everybody's like looking over at him. It was like Michael Jordan walked in the room, and they called his name out before the conference started, and he stood up in the entire place. And I'm like, for heaven's sakes, I didn't know I was sitting here with the most important guy in the whole country. He had that much, engagement and just poise. It was really phenomenal. And he gave me his autograph after too.
Did you really? Are you kidding me? I wouldn't put it past him. Yeah.
All right, so then lastly, there's the idea of, this is an important idea I want to share with you, so being heard, the person, the patient or the client, and being listened to, when those are in harmony, that's when we actually have the best opportunity. So we have to teach the providers what that means. So they have to learn how to listen, right? So we have to give the voice strength. And that does not come without education. We are not taught to listen in medical school. I can promise you that. We're taught to think independently, act independently, control a situation, sometimes disregard every piece of data that's put in front of you, doubt it, second check. Those are not exactly collaborative ideas. They're changing that, fortunately, but that's what the vast majority of 40 to 65-year-old physicians are going to think. And then obviously it's more about the collaborative idea. So it really changes the management of chronic medical problems when you start having this harmony between the person who is making the choice and the provider who's aware of it. And that was the biggest part of what I think, Trish and I learned over time as we talked about some of the chronic issues related to her transplant. And really, it's ultimately about empowerment, right?
Oh, yeah. Yeah.
All right. So any final thoughts, Trish?
No, but last time I saw the neurologist, remember I told him what was wrong with me? And he agreed. So there you go.
Because there was nothing wrong with you, right?
Now it was that migraine thing.
Right. Yeah. Oh, that was very fun.
Yeah, that was a lot of
Trish,
fun.
well, Trish was in the hospital and she told the neurologist her diagnosis. And the next day after multiple tests, they said, yeah, I agree.
Boy, was that felt good.
So she's on
right?
speed dial for me for second opinions. I just keep her close. All right. So thanks for having us, gang. If you guys have any questions, I'd be glad to entertain them.
That was fun.
And let me, just for a second, it's a little selfish, but one of the things you didn't touch entirely on, Trish, but you hinted at it, was there has been in Ohio, at least, a push for peers to be more involved. Trish touched on this, but Trish and I have talked about this issue, and I think she is representative of a group of folks in Ohio and maybe other states where, the structure to be a certified peer in Ohio, it's a process. Maybe it's a good process. I don't want to judge it. I'm just saying it's a process. There's a lot of steps, to get Medicaid reimbursement, et cetera. So to some extent, what they've done is professionalize being a peer. Okay. And to some folks, that sounds really good. But when people, we talked about that and Trish hinted at it. Not all peers want to be professionalized, right? They feel like it actually takes away some of their flexibility. And they said, David, if I want to be a counselor social worker, I would have gone to school for that. I want to be a good friend. I want to have the flexibility to be effective. So is that a fair representation when we talk? Because I know you're not the only one, Trish, that maybe it's not that you don't want to be a peer, you consider yourself to be a peer, but not in the way perhaps that is being kind of advocated right now by the system.
I don't want to be a peer, like a peer in an office. I want to be a peer that's available to people when you need me, not when on Thursday at 2:00, 2 weeks from now. Because by that time, whatever's brewing is happening. And a lot of times I take calls in the evening. And that's, now this is the money thing, right? And every time I keep somebody from the hospital, how much money does that save you?
Right.
Or any peer, keeps, supports that person through that crisis. And not only that, but it saves them going through the trauma of, having the police pick them up or, all that stuff, all that drama and trauma.
So keep that in mind if you're trying to develop peers within your county or your system. And I think it's okay to have both, like this is what I'm saying. I think you can have a group of folks that want to be involved but don't want to go through the formal, but then you got some folks that want to go through that formal process. I don't think it's.
But it doesn't hurt to go through the process and get certified. I think the classes are good for anybody, not just if you want to be a certified peer, but definitely if you want to be a certified, if you want to be a volunteer or a paid peer. I think the classes are, or just anybody. The classes offer a lot of education for anybody. And if you go through that class, you will learn something about yourself that maybe you didn't know that you need to know.
Yeah, and a small plug, Deb probably mentioned this, but in Ashland County, if you're interested in being a peer. Pathways Peer Support acts as a support and hub and a kind of a resource center. So if you're really serious about doing it, it's not something I think most folks can do without some support.
Yeah.
It's complicated. It's a lot. There's just a lot of steps. So that's great. We talked to her about going through that.
And
process.
Pathways offers some group on boundaries and stuff, so that even when you go through the classes, you come out with a better sense of, where you fit in and all of that stuff, what's ethical and what's not. And yeah, so that's a little additional stuff.
So questions for Dr. Mooney and Trish. I know we're getting close to the hour, but I'm sure we have one or two. We have either online too, Ashley. I won't forget about you. I see that hand.
You first.
Mr. Old Pastor.
So that might be for you though. That much might be for you. You first.
Really? I don't remember 90%.
So I just want to take the time to really acknowledge peer support. We come from the state mental health hospital system, and we have a great peer support department, and people that we see when they come in, as soon as they come in, they don't want to see the doctor. They're like, "Where's George? Where's Christy?" Because they have that connection with them. And in some research that I've done, actually, peer support is the #1 thing that kept our dually diagnosed patients out of the hospital. Was
Wow.
having that connection to peer support in the community and keeping them sober. So I can't validate enough all the things that we've heard about peer support. They are absolutely 100% true. And I think they're the future of mental health.
Yeah.
As much as the state can support it, we will.
Yeah.
This question is actually for Dr. Mooney.
Say I told you.
And talking about trauma-informed care principles, ACE studies, and patient-centered care, how receptive are your colleagues in discussing that and implementing that into their practice from your experience?
Yeah, it generally depends on the extent of their emotional health. So that's what I do. I basically try to assess that before I talk to groups. But generally speaking, I would say that they're not particularly receptive to it because it's unfamiliar. But as soon as they get to realize that it's the base of everything they're doing, it does intrigue them. And then I start putting data in front of them, like the results of the adverse child experience study. And then I put the costs associated with the care, and then it becomes a pretty straightforward argument. But what I'm always mindful of is the one who's the least attentive to the discussion is probably the one that needs the most attention, because they're so resistant, because I'm probably striking a chord and their emotional health is probably compromised. And so if they're pushing back, or if they're aggressive with me, or if they're dismissing me, then I just say, okay, I'll circle back around, because I have to be more compassionate to them because they probably have a lot of trauma.
Okay. Additional questions?
I don't have one. Oh,
go ahead, I'm listening.
okay, sorry. We just have one from an online attendee that says, what can be done for people who proactively seek support for iatrogenic injuries when providers are unwilling to provide comprehensive assessments and rehabilitation to quantify an injury that they caused?
Was that the summary?
That was the question.
I caught it. It was about, is it about follow-up for iatrogenic injuries? Was that the
Yeah.
question?
Yeah.
Yeah, so everybody kind of knows iatrogenic just means that it was imposed by the system. So that's on the physical side, we created a problem for that. My hope is that it's recognized. I mean, an iatrogenic problem is a clear complication. And so if I think what the person might be experiencing is that they get blamed for the problem. So the patient actually owns the problem, even though they didn't create it. And so every time they go to the next person, they don't want any part of it because there's a complication associated with it. So that's a good point. They need advocacy. I mean, that's where, somebody like Connie at the hospital would be in communication with me and say, Jim, I have a patient here that really needs assistance and we need to coordinate care. So my recommendation in that setting would be to access the system through a social support realm. And then that person would hopefully find somebody who's going to be an advocate for that iatrogenic problem and get the appropriate stuff scheduled, be it physical therapy, occupational therapy, follow up with a specialist, whatever it takes. And I was a chief medical officer, so if Connie walked into my office and I know she would support this statement, if she asked me to do this, I would make sure that got taken care of.
I don't have a question necessarily, but I have 3 daughters and 2 of them have chronic illnesses. One from birth and one due to long COVID. And it's never too early to get them to advocate for themselves. My 13-year-old had a big victory. Her neurologist finally diagnosed her on what's today? Wednesday, Monday. And she was like, Mom, I did it. She had all her friends on Instagram. She posted about it. She goes, they finally listened. And I said, I don't think they're gonna watch it. I was so happy. But she did it herself. So it's never too early to teach, especially women in medicine. It's never too early to teach them to be themselves.
Yeah. Well said.
What are your recommendations on creating a paradigm shift in terms of, moving away from the disease model, particularly for mental illness? Because earlier somebody talked about the liability. And so there is a perception that by not prescribing, it creates more liability. But when you do prescribe and something goes wrong, it's the drug's fault, not the doctor's fault. And so that's, if I was somebody giving the prescription, if I was the medical professional dealing with the pressures inherent in the system on that, how do we change that?
Yeah, that's the $1 million question, right? I mean, the vast majority of physicians are employed now. So not only is that overriding expectation there, but that's the system thinking that we have to change. And we are very far from the system changing. So what I always do is I go to dollars again. So what I did actually is I went out to businesses who pay for the healthcare costs of the employees who know nothing about healthcare and showed them how expensive all this stuff is. So if you look at the top 10 causes of expenses in self-insured companies, and we're talking in the hundreds of millions of dollars, in the country, we're talking multiple billions of dollars. In the top 10, there's 2 categories that relate to emotional trauma from things like diabetes, obesity, hypertension, hyperlipidemia. It has to do with how we manifest our self-treatment plans. And the second one is emotional health, anxiety, depression. So what I'm doing is I stepped outside of the hospital realm because every time they consume healthcare, they make more money. And I went to the people paying for it. We have to teach the people who are paying for it that you're wasting your money on this stuff. And they listen because it's $1 directly out of their pockets. So I think that could be a great way to do it.
We might have to keep this guy, right?
You wouldn't get much if you traded me in, so you might as well keep me.
Well, we're just about at time. Let me do a couple things before let's first thank Trish and Dr. Mooney, but then don't leave. I have a few closing announcements, so let's thank them.
Come on, let's go.
Okay.
And I gotta help Trish because I promised that I would.
Yeah.
Yeah,
I expect to be carried. That's what you
Yeah.
said, right?
yeah, Steve.